sure you're recording.
I am recording.
Okay. So, what is your job?
I am a pediatric hematologist oncologist.
And how do you do it?
How do I do it? Well, I work here at Children's Hospital of Pittsburgh, and patients who have cancer come to the hospital, and then I have to figure out how to get them better.
What is the most severe/difficult cancer to treat?
Ooh, that's a good question. There's a type of cancer called a brainstem glioma, and unfortunately there's no known cure for that one. So that one is the most difficult to treat.
And what is the most difficult method of treatment? I guess.
How so?
Like radiation or the chemotherapy of some sort.
So I think probably the most difficult thing that a patient would have to go through is a bone marrow transplant. That involves like really high dose chemotherapy, and it involves radiation therapy, and they're sick for a really long time and have to be in the hospital for 6 to 10 weeks.
Okay. And what is the easiest to treat?
What is the easiest to treat?
Or treatment itself.
Oh, you mean like least intense treatment? There are some tumors where you can just take them out. With a surgeon can go in and do like a very minor surgery and take it out, and all we do is monitor them afterwards, and those are the easiest to treat.
Okay. What is the most up-to-date tech you're working with?
Well, the most up-to-date technology that we're working with, so we run everything off of protocols, and we were part of a group called the Children's Oncology Group, and so this little lady here was treated on a study using Children's Oncology Group data, and so we are always giving patients the most up-to-date and technologically advanced therapies by offering them studies on those Children's Oncology Group research protocols, and that's what resulted in this one being fixed. Cured! Ugh!
Do you have any, how does that work itself? Like the program or
the tech? Oh, yeah. So a lot of work. So we're always looking for new drugs, and so it starts very early in drug development phases, and so that starts in a laboratory where people are taking cancer cells and they're exposing them to lots of different chemotherapy drugs, or to radiation, or to some other, or to the immune system of some sort. And then those drugs get tested in animals, lab rats, and then those drugs then get tested in patients. And then those drugs get introduced into what's called a phase 2 study, where they're used in patients to see if they actually work. And then that ends up being in a phase 3 study, which is what Joey was treated on, where we're actually treating large groups of patients. So it takes years in order to come up with a new therapy for a different type of cancer.
Okay. How much education did you get, and where did you get your education?
Okay, you ready for this?
I sure am.
All right. So I graduated high school in Niles, Michigan.
Okay.
And then I went to college at Wittenberg University. That was 4 years. Then I went to medical school in Portland, Oregon. That was 4 years. And then I did pediatrics residency training at the University of Washington in Seattle. That was 3 years. And then I did pediatric hematology oncology training at St. Jude Children's Research Hospital in Memphis, Tennessee. That was 3 years. And then I got my first job when I was 32.
And how much school is that altogether, you say?
4 plus 4 is 8, plus 3 is 11, plus 3 more is 14. 14 years after high school.
Jeez. How much does treatment usually cost?
Oh, millions of dollars. Yeah, it depends on how technologically advanced the treatment is. There are certain treatments that aren't that expensive, but we estimate that to treat a patient with leukemia is somewhere between $750,000 to $1 million.
How much does equipment that you use cost, like the big radiation machines or the...
Oh my gosh, I have no idea. Probably millions of dollars, I'm sure.
I'd assume so.
Yeah.
What is the average salary?
The average salary of someone in my job
Yes.
is probably like around $130,000 a year to $150,000 a year, something like that.
This is more towards the X-ray or the radiation? Do you know anything about the radiation?
I know lots about radiation.
Can you describe the different particles that are used? Like, I think I have photons. And I don't remember what the last one was. Yeah, photons.
Yes. So there's several types of radiation therapy. So there is regular radiation therapy, which just gives you a block of electrons being shot towards the body. It's very crude. There's another type of radiation therapy that's more advanced called conformal radiation therapy. And that's where the machine shoots a beam of electrons towards the tumor, but it does it in a rotating way around the patient.
Okay, I think I've seen something like that.
Yeah, where they rotate around. Yeah. Yes, exactly. It rotates around the patient, and it's shooting beams at the tumor from all sides, and that makes sure that the radiation gets mostly on the tumor and avoids healthy tissues around it.
Okay.
So that's currently what we use. And now there's a new type of therapy called proton therapy, and that's different. Instead of using electrons, it uses protons. And the benefit of that is, again, it's more focused and gets it only into the tumor. But the difference between conformal radiation and proton therapy is very, very controversial right now. And there are some people who think that the conformal therapy is just as good as the proton therapy, but the proton therapy is much more expensive. And there are certain people who think that the proton therapy is much better, and that's why we should spend all this money on it. And so those people are fighting right now.
Okay, and that was the three-dimensional conformal radiotherapy, right?
Yep, that's what it is.
All right.
You got it. You've been doing your homework.
I have. What inspired you to be an oncologist?
What inspired me to be an oncologist? It's kids like Joey. So when I was in college, end of college, getting ready to go to medical school, I was a camp counselor at a YMCA summer camp, and they had a camp for kids who had cancer, and I got to meet all of these kids who had cancer, and I thought to myself, this would be a really good way to spend my life and what I'm doing. And so I decided I wanted to take care of kids with cancer. So that's what I do.
I have a question here to see if I can see some of the equipment, but I don't think you're allowed to bring like electronics and stuff by it anyway.
Right. Well, it's downstairs, and you know what? I could actually give you a tour of it.
Really?
But it's closed today.
Oh.
Because
Alright.
it's the day after Thanksgiving.
That's
That
fine.
stinks. But if you ever come back and want to see it, I can show it to you.
All right, cool. How has research changed with the advancements in technology? I guess the biggest change. I'd say.
So actually, you are in the right place for that, because let's just take the type of cancer that your sister had, the leukemia. When we first started treating leukemia, the cure rate for leukemia, which is the most common form of childhood cancer, was 4%. And now today, because of research advancements in radiation therapy, research advancements in chemotherapy, research advancements in clinical trials, we now have a cure rate of over 90%. And in fact, there are certain subsets of children with leukemia where we have a 98% chance of curing them. And so 50 years ago, we were at 4%. And now, 50 years later, we're at above 90% for all comers. That is an amazing difference, and there is nothing in modern medicine that is even remotely similar to that change in success rate. And that's all been done through research. And the cool thing is that patients like Joey, who have participated in research, they're going to be part of the next generation of studies. Like, all the information we learned about treating Joey is going to be used to make the next chemotherapy protocol for leukemia. And so she's going to be part of when I am able to go into a family and say, oh, it's leukemia, there's a 100% chance I'll cure this.
So she could, because of her research, can cure someone else.
Exactly. Exactly. And isn't that cool?
This is a little darker question, but is there
Okay.
any psychological damage?
Oh, yes, there is. So, many patients who go through cancer therapy, even those that are cured, can have symptoms of a disease called post-traumatic stress disorder, where they relive events either through their treatment, or they're afraid to do certain things because they're worried that their cancer will come back. The parents of these children often have psychological issues because, as you can imagine, I think you probably are aware, when your mom and stepdad were going through this, how stressful it was on them to have a child who was sick. So parents have a lot of psychological issues. The other thing is, you bring up radiation therapy. Patients who get radiation therapy to their head, they oftentimes have neurologic issues. They lose IQ points, they lose ability to participate in school. Oftentimes patients who have gotten really high dose radiation to their brain, we may cure them, but they're not able to be functional members of society. And so there are a lot of side effects from the treatments that we give kids. But right now, especially in diseases like leukemia, through research we were able to actually, it used to be that every kid with leukemia would get radiation to their head, and now we're able to eliminate that. And so, yeah, so Joey never got that. So as we continue to make advancements and learn more and more and more about these cancers, the treatment-related morbidity, meaning problems caused by the treatment we give kids, is less and less and less and less. So we're getting better. But there are certain tumors where the treatment, we really need high-intensity treatment to cure them, and sometimes the outcomes are not as good as we would like them to be. So we have to keep working.
See, how much, or how far, or how much do you see research or even just radiation advancing in the oncoming years?
Leaps and bounds. We will be, we've already got a new protocol open for kids who are presenting now with leukemia, different from what your sister got. We are also developing new therapies all the time. There are new drugs. We're figuring out new ways to harness the immune system. The latest thing in leukemia therapy is actually taking cells from a patient's body and training those cells to fight leukemia, and then giving those cells back to the patient. And it's really, really cool and really, really exciting. And so we're growing leaps and bounds, and it's moving lightning fast. So that's good.
What would you say your average routine is?
My average routine? I get up at 6 o'clock in the morning. I try to get some exercise. I get to work at 8 o'clock, and I'm here until 6 or 6:30 at night. And then I've got 2 kids at home that I have to wrangle, get them to bed, get their homework done, and then I usually have some work to do at home at night, and then I go to bed. But that's my gig. I see patients pretty much every day, and then I do research as well.
Can your expertise transfer to any other careers?
I would think so. The thing about treating cancer is it's what we call interdisciplinary, meaning that we work with lots of different people. And so, for example, there's a doctor that administers radiation therapy called a radiation oncologist, and I work with that doctor a lot. There are psychologists that help take care of our patients and their families as they go through, and I work with them a lot. There are child life specialists who help the kids cope with their therapies and things like that, and I work with them a lot. There are lots of different doctors that were involved in taking care of your sister and many other cancer patients. And so, yeah, a lot of the things that I learned can be translated into other areas of medicine. But also, things that we learn about taking care of cancer patients can translate into other areas of medicine, like learning about heart disease or learning about Alzheimer's. All of that stuff is interrelated, and we're able to learn about a lot of different things.
What types of, external, can you explain external beam radiation and internal radiation therapy for me?
Yes. So external beam radiation therapy is the sort of the typical thing that we kind of talked about before, which is where the patient's lying on a bed and there's a radiation machine that's shooting a beam of radiation to the tumor. And then internal radiation is where they take, and we don't do this in pediatrics at all, but this is something that's done in adult oncology, where they actually take these little beads, or seeds they call them, that are laced with radioactive nucleotide, and they implant that around the tumor to try and get radiation just to that tumor. And then sometimes they leave them in, and sometimes they go back in later and take them out. That's called brachytherapy, but that's an internal radiation.
Is that because it'd be more dangerous to the kids, or is it just?
We just So the tumors that we treat in pediatrics are just not amenable to those therapies. So oftentimes that therapy is used for stuff like prostate cancer, and so it's more studied in them. I've actually never used internal radiation to treat a patient.
Okay. Radiopharmaceuticals, can you explain some of that?
Ooh, radiopharmaceuticals.
Any top of your head maybe?
So one thing that we use in pediatrics is called MIBG therapy, and MIBG stands for a really long radionucleotide name. So there's a type of cancer called neuroblastoma, and we know that neuroblastoma cells are really selective for taking up this MIBG ion, and what we're learning to do is take that molecule and attach a radionucleotide to it that causes whatever binds that to die. And so these patients go and they get this therapy, and the therapy is injected into their bloodstream. The tumor takes it up and is killed, but while that's happening, the patient's actually radioactive. And so they have to be in a lead-lined room, and anytime they urinate or have a stool or anything like that, that has to be all like put into a lead-lined container and disposed of properly because it's all radioactive. And so I have one patient who I had to do this.
So if, for instance, you took a Geiger counter, you could actually...
Yeah, yes, exactly. The other thing that we do in pediatrics, and it's rare in pediatrics, but there's a type of cancer called thyroid cancer.
Do that with phosphorus 32, is that used?
Yeah. I think so. Iodine 131 is typically what we use, but I think there is another.
I have that down.
Yeah. Yes, there is, and so thyroid cancer is really, really rare in children. So I've actually never treated it, but I've seen it done in other patients where they also have to go into a lead-lined room, and all of their urine and all their has to be disposed of properly. So yes, that radiopharmaceuticals is an area that is still used today.
And I have a bunch of terms down. I think it's helical tomotherapy, or if I pronounce that wrong. No.
I have no idea what that is.
Volumetric modulated arc therapy. I have fourth dimension down. I think
I think what that's referring to is new techniques in conformal radiation, where they're looking at how to isolate. If you think of a tumor as a ball in space, it's thinking about how to attack it from multiple different ways. So almost in a four-dimensional kind of way of thinking about things, so that it's just hitting the tumor and leaving all the healthy tissue around it alone. I believe that's what that refers to.
What are the most common side effects of
radiation?
Yes.
So the most common side effect would be fatigue. Patients, if let's say I was getting my hand radiated, they can get redness. You can get redness at the site. The skin can peel, almost like a sunburn. If you're getting radiation to your brain, it can cause swelling in the tissues around there, and so you can get signs of increased pressure on your brain, like nausea and vomiting and headache. Sometimes those symptoms can be very severe. The other thing is if you give too much radiation to an area, you can have what we call tissue necrosis in that area, which is necrosis just means dead tissue. And so that's why we have to be very careful about the amount of radiation we give, because if you give too much, the tissue will die. And each part of your body has a different sensitivity to radiation. For example, your bones and your muscles, they can handle a lot of radiation, whereas your brain can handle only a certain amount. And then your lungs are really wimpy. If you give too much radiation to the lungs, then they'll just disintegrate. And so you have to be very careful with the amount of radiation that you give somebody, because you could cause this tissue necrosis.
Would you say the lungs are the most sensitive to the radiation?
The lungs, are probably the most sensitive area of the body. The other area that's really sensitive is thyroid. In fact, you can knock someone's thyroid out really easy. Even if you were just trying to radiate something, like maybe they have a tumor like right here, you can actually knock out someone's thyroid through scatter.
What is it like to work with the children?
What is it like to work with children? I love working with children. They're fun. They keep me young. I have to stay up on like pop culture. I have to know what everybody's into, like the latest toys and the latest crazes and who, like Taylor Swift and Justin Bieber and all that. I gotta stay up on that, otherwise I'll have nothing, no idea what they're talking about. But I love taking care of kids. I would never take care of anybody other than kids.
Okay, here's a controversial question. How do you feel about the 4% going to research?
The 4% going to research. You mean, what are you referring to?
What was it? The
government
cancer
funding.
research only 4%?
That only 4% is going to childhood cancer? Yeah, that's what I thought we were referring to, but I just wanted to say it. Yeah, I think it's, on the one hand, I understand why it happens. The good thing is that childhood cancer is extremely rare. The bad thing is that when we neglect research for children with cancer, we're neglecting all of the great strides that we've made through all of the research that we've been doing for years and years and years. Adult cancer, you're pouring millions and millions and millions and millions of dollars into adult cancer, and they have nowhere near the success rates and improvements of care that we have in pediatrics. The other thing is I think that our children should be our highest priority in society, and so curing them should be our #1 priority.
They're the future.
They are our future, right? And research saved this one's life, and I think that she was worth it.
I think so too. What are some restrictions?
Restrictions
I'd say with
to research.
that and maybe just radiation. Well, both. I guess radiation, some restrictions with pediatric and research. I'd say.
Do you have? Hold on 1 second. Do you have 5 minutes?
Yeah.
Okay.
I can come back.
We can finish this.
Okay.
Are you almost done?
Yes.
All right. Cool. Here, sit. You're good. We're good. All right. Restrictions for radiation. So the biggest restriction for radiation is that I think it'll be like 2 minutes, Stacy.
Take your time.
Okay. The biggest restriction for radiation in children is age. So we cannot give radiation to the brain of anybody less than 3. So if we have a child with a brain tumor and they're less than 3 years of age, it's too dangerous to give them radiation because they'll die, basically. And so it's very tricky to treat brain tumors in children under the age of 3 because of that reason. The other thing is, as I said, if you give radiation to somebody, it results in functional difficulties later on in life. So even if we give radiation therapy to older kids, if we're giving high doses of radiation to the brain, then we sometimes have situations where those kids are not able to participate in society in any meaningful way. They can't get a job, they can't maintain concentration. Oftentimes they have very, very low IQs, all as a result of the radiation therapy. The other thing is, sometimes you'll have a tumor that you could kill if you could just give a high enough dose of radiation, but because, let's say it's in the lung, you can't give a really high dose of radiation there because the lung will just disintegrate, and then the patient will die because their lung disintegrated. Exactly. So those are limitations to radiation therapy that are really hard to get around. The limitations to research are just resources and money, and unfortunately adult cancer gets way more money than pediatric cancer, and those are reasons that I don't really understand.
What programs are associated with radiation?
What programs, as far as types of programs do you
I'd
mean?
say research maybe or that funds the...
That funds, so the National Institute of Health is run by the US government. They're the largest funder of cancer research in the country. Then you have independent groups like the Children's Oncology Group, which raises money independently of the federal government. So sometimes the federal government contributes to the Children's Oncology Group, but sometimes the Children's Oncology Group has to seek private donations in order to conduct its research. And so those things, those programs come in and support research in radiation therapy, research in chemotherapy, research in cancer therapy in general. And so all of those things go into creating funding to treat the types of cancers that we have. And then sometimes there's private foundations issued by families that help us support research and things like that in cancer.
Can you describe the goals of therapy? I guess, I already know, but describe anyway.
Right, yeah. So goal number 1 is to save the patient's life. Goal number 2 is to save the patient's life with the least amount of risk during treatment and the least amount of deficits to be suffered by them after treatment. And so those are the major goals of therapy. So, you know, we want to always try and save the patient's life, and then the number two goal is to maintain the best quality of life we can for them, in the event that we can cure them, and also in the event